We tend to think that every era brings new opportunities when it comes to transplant, and what we're finding out is how to sequence transplant in with newer treatments as they become available. I mean, obviously, every time a new drug comes out, people hope that that's going to be curative in and of itself, and if that's the case, then we adjust to that. But the fact is that there are always new treatments that we want to interface, and learning how to use the standard treatments in conjunction with transplant, or in some cases instead of transplant, is what makes this a multidisciplinary approach. So working with the patients, referring oncologists and referring physicians allows us to pick the best patients for the procedures that we're doing, use the new treatments for the people that need them and can benefit from them, but to use the transplant procedures for people that need that. And trying to parse out who's going to benefit and who isn't is the important part of what we do. It is as important for us to decide who doesn't need a transplant as who does. Our goals here and our standards here have always been national standards. Ever since I set the program up many years ago, we have always compared our data to national data, not to our own data, not to the data down the street or around the corner, but to national data. And every patient we transplant here is recorded into a bone marrow transplant registry, which allows us to compare how we do with national and in some cases international standards. So we feel like our standards are the standards of the country, and because we're audited and accredited on a regular basis, not only by insurance carriers but by national standards rankings institutions, that allows us to periodically examine our data and see how we're doing. Most of us would not be doing this if we felt that there was a better place to have this done, and that's been a goal of our program from the get-go. So it's important for us to have access to the information, to know how we're doing, to compare our patients to other patients, to make sure we are doing state-of-the-art treatments. As far as the numbers are concerned and how we're looking forward to, we're always looking to bring these aspects of treatment to more people and make them more available and make them more eligible for these kinds of treatment by increasing our ability to treat sicker patients, to reduce the toxicity of the procedure itself, and to support our patients better so that we can treat people that are potentially sicker. The outcomes for us, I think, have been what they've been nationally, and given that the people that we start with are universally folks that have failed primary therapies, you're looking at a group of people that without our therapy would likely die from their disease, and we've been able to improve those odds substantially for many of those people and cure quite a few of them. But there are still goals to be met. There are still standards that could be raised, and we're constantly trying to do that. I think that the end result with transplant, as it has always been, is to sequence that in with other therapies in a meaningful, smart way that gives the most benefit to this very strenuous treatment and finds the right patients for it. Transplant has never been a last-ditch treatment for anything, and that's been the case since the first days of leukemia transplants. When you wait until someone's at the last ditch, it's not a good time to use transplant. So we have tried to be reasonable about when we offer transplants to patients, but by the same token, we've been trying to increase the awareness of transplant as an option for people before it becomes the end of the road. Mm-hmm. It is a self-fulfilling prophecy that people that start into transplant on death's door often don't do well, and we don't want to get people at that stage. We'd like to be involved earlier in their care. And this goes back to what I said earlier about picking the right patients and sometimes telling people they shouldn't have a transplant. Right now, there's controversies in areas like this, and as I said before, every time a new treatment comes out, every time a new drug is developed, every time somebody comes up with a new discovery, there is always a rush to try that treatment first. And that's as it should be, but by the same token, you have to understand that new drugs often give early results that are very encouraging, but then subsequently they don't look so good. What we're trying to do is that we're trying to be reasonable about transplant. Stem cell transplants have been around a long time. The data on the treatments that we use have been published in multiple ways and looked at in multiple aspects at this point, and so we have a pretty good idea of where we stand. I think the real issue is how do we work with these new drugs to develop new treatments and possibly coordinate what we do as a consolidation for treatment that other people are using. And it's seductive to try to use new drugs all the time because they look so good, and we're always so desperate for these drugs. But I think that it's important to remember that you have to be careful about jumping too early with new treatments, because oftentimes you'll be disappointed, and you're dealing with a person whose life may depend on making the right choice. And sometimes what's new and interesting early on turns out not to be the right answer. It should never be considered to be routine or dull or boring, because it never is. But the fact of the matter is that our data is data that's been around for a while, so we know where we fit, and we pretty much know how people will do. We know the long-term effects of what we do, which often isn't the case with new treatments. So while new treatments are great and we're all dependent on them, and new discoveries today will end up being the cures for tomorrow in many cases, you have to be careful about how you sequence that, and remember that for a given patient, you don't have multiple choices to make the right decision. Sometimes you have to do something that may not be as new or as interesting or as shiny, as you put it, as an older treatment, but it's still the right thing to do.